Hey everyone, I hope this podcast and my blog and books have been helpful resources for you and will continue to be. But if you've been struggling with a chronic health problem and are feeling stuck, consider coming to work with my team and me at the California Center for Functional Medicine. We work with patients all over the US and have experience treating a wide range of conditions, including GI problems, autoimmunity, hypothyroidism, cognitive mood and behavioral issues, weight gain and metabolic dysfunction, and more. Our unique model teams clinicians with nurse practitioners and health coaches, all of whom are trained in my ADAPT framework approach to provide a high level of care to our patients. This means more support between appointments, personalized guidance on diet, lifestyle, and behavior change, a cutting-edge patient portal with 24/7 access to your labs and records, handouts and resources to guide your protocols, and a team of practitioners working together on your case. We're currently accepting new patients, so if you'd like to learn more, visit chriskresser.com/become-a-patient. Hey everyone, Chris Kresser here with a brief message before we begin the podcast. Imagine a career that draws on your passion for wellness and disease prevention, that harnesses your ability to support and connect with others, that helps you to develop as a person while you help others to do the same. What if you could earn a living while making an impact on thousands of people's lives and even on the future of healthcare? That'd be pretty great, right? Well, that job does exist. It's the job of a health coach, and I believe that health coaches will play a crucial role in the future of medicine, not only in the US, but around the world. 1 in 2 Americans now has a chronic disease, and 1 in 4 have multiple chronic diseases. Chronic disease is destroying our quality of life, shortening our lifespan, bankrupting governments, and threatening the health of future generations. And our medical model is not prepared to address it. Why? Because the only way to prevent or reverse chronic disease is by changing our diet, lifestyle, and behavior. And conventional medicine is simply not set up to do this. Bottom line, we need people who can provide this support to help people make the changes they need to make to save their lives. We need empathetic and compassionate people with a skill for connecting and a passion for change. And my job is to make sure they have all the training they need to do their job so well they will change the future of healthcare. A career as a health coach can be incredibly fulfilling both professionally and personally. It really could change your life, and it can also change the world. That's why I'm excited to announce that we're launching the ADAPT Health Coach Training Program. It's a 12-month, 100% online certification that will prepare you for a successful career as a health coach. It includes training in core coaching skills, functional health, ancestral diet and lifestyle, and professional development. And it's unlike any other health coach training program currently available. To be notified when enrollment opens and to learn more about the program, visit kresser.co/success. That's KRESSER.co/success. Now on to the show. Hey everybody, Chris Kresser here. Welcome to another episode of Revolution Health Radio. This week I'm really excited to welcome my colleague from the California Center for Functional Medicine, Dr. Ramzi Asfour, as my guest. Dr. Asfour is board certified in infectious diseases and internal medicine. He graduated from New York Medical College, then completed an internal medicine residency program at California Pacific Medical Center, followed by a fellowship in infectious diseases at UCSD. He's worked for the World Health Organization, WHO, Columbia University in South Africa, and the University of California, San Diego. Prior to attending medical school, Ramzi minored in genetics at UC Davis. He is currently Assistant Clinical Professor of Medicine at UCSF. And I've had the pleasure of working with Dr. Asfour for the past couple of years at our clinic, CCFM. And I'm looking forward to talking with him about a really interesting poster he presented at a celiac disease conference, establishing a possible association between genetic susceptibility to celiac disease and chronic Lyme disease. So let's dive in. Dr. Asfour, thank you so much for being here. I've really been looking forward to this.
Thank you, Chris. I've been looking forward to it as well. It's about time we do the podcast together.
That's right. I've had the pleasure of working with you at California Center for Functional Medicine for So how long has it been now since you joined us?
Going on the third year, so about 2 full years.
Time flies. Yeah, it's been amazing to have your infectious disease and other expertise in the clinic, since so many of our patients are dealing with various forms of infectious disease, and I really enjoy getting to know you and working with you.
Thank you. Likewise. Yeah, it's been a pleasure.
All right. So for the listeners who may not be familiar with you and your work, why don't you just tell us a little bit about your background, both in conventional medicine and then how you switched over to the dark side and joined us in functional medicine.
Some would say most of your listeners and myself would have it the other way around.
That's right.
So I saw the light. So
saw the light.
I did medical school in New York and internal medicine residency in San Francisco at California Pacific Medical Center. And then I was always interested in infections, infectious diseases, and international health. And so I went to a fellowship at UC San Diego, University of California in San Diego, in infectious diseases. And while there, I, of course, learned regular infectious disease practice, which for those of you who don't know, that's more of a hospital-based practice. So you see some patients in clinic and definitely a lot of HIV, but most of the time you spend working in the hospital and then doing research. So I did research in HIV and also clinical research, and mainly in infection control and also HIV and care projects in Africa, mainly Ethiopia and South Africa. And so when I finished my fellowship, then I worked in South Africa, setting up HIV care and treatment clinics. And then I worked at the World Health Organization in Geneva. I was basically the head of doctor training for an HIV program and training doctors mainly in Africa on HIV. And then family and I really love seeing patients and the patient care. And so when I was at the level of the World Health Organization, I didn't have that patient touch. And that's really what I enjoy especially about functional medicine. So I went back to the States. All my family's in Northern California. And so we moved back, had kids. I worked in conventional internal medicine and then infectious disease. So I've done about 16 years of infectious disease practice. But the last few years of my infectious disease practice, I had a lot of patients who I couldn't help in the conventional paradigm, either Lyme disease or strange autoimmune disease. And then my daughter developed celiac disease. And it wasn't me that diagnosed her. It was my wife, who now she's an acupuncturist and Chinese medicine doctor. But at the time, she didn't have that training. And she said, something's wrong. And we had Kaiser, and she convinced the Kaiser doctor to do the tests, and then we found out she had celiac disease. And so that was the start of my journey into finding a different approach. And my own family, his story, as many of us have, and then the fact that there were a lot of patients that I could not help. And I did training with the Institute for Functional Medicine. I met Sunja Schweig, who is your colleague at CCFM through a mutual friend. And Sunja and I hit it off, and we've been working together basically ever since. And I've done your ADAPT training program as well. And now I'm really enjoying the practice of functional medicine. It's very interesting. I keep a foot slightly in the conventional world. I keep some hospital privileges, and I do a little bit of infectious disease telemedicine, but my joy is functional medicine, and I love that patient contact and helping patients in that domain.
Mm-hmm. Yeah, I wish the story of your wife was rare, where someone suspects they have gluten intolerance or celiac disease, and it's not the doctor that initiates that testing, but the patient. And of course, we're going to be talking more about celiac, but it strikes me that it's one of the few autoimmune diseases that's relatively easy to treat, comparatively at least to something like multiple sclerosis, and yet it's still dramatically underdiagnosed.
Absolutely, that's one of the major issues with with celiac disease. I mean, it's easy to treat. It's not easy to avoid gluten for sure. So I don't want to minimize that, but
Yes.
it's not like multiple sclerosis by any means.
Mhm. Yeah. And for every person who has the typical form of celiac, where there's, severe enteropathy and diarrhea, after eating gluten, and that kind of very clear chain of causality between eating gluten and having a reaction, there are 6.2 cases of atypical celiac, where it might manifest as brain fog or muscle pain, myalgia, or skin, dermatitis, or any other type of skin manifestation. So, in the defense of doctors, it can be a very tricky. It's not necessarily disease you can always just diagnose based on the symptoms.
Absolutely, absolutely. And I think that my daughter's manifestation, for example, was ADD. She had ADD, and she had actually lost a little bit of weight, but living with her every day, I didn't realize she was 4 years old. She should not be losing weight.
Right.
But it was ADD. She didn't have diarrhea that most people would complain about. So in my practice at CTFM, I test everybody for celiac disease now. And I think that, people presenting with vague complaints or even no complaints, I think it's in our population, it's worth screening for celiac disease. Screening in the conventional world for celiac disease is controversial, to say the least.
Yeah, but in a population of people who are seeking out functional medicine, who have complex, often very chronic, often mysterious symptoms, and who are motivated enough to pursue functional medicine, the calculus there for me, and I know for you, is that the impact of having it far outweighs the small expense and trouble of screening for it. In other words, if you find it, it's going to be a game changer. And if you don't find it, it's going to get in the way of everything else that we're doing.
Absolutely.
Right.
Absolutely. Even that there was one study I was reading talking about for screening. They were saying, well, even people who don't have any symptoms, if they find out by a screening program that they have celiac disease, even if it's mild, and then they avoid gluten, they will feel better. So some people might not think they have symptoms, but then after that diagnosis, and I'm sure you've seen that, we've seen this in our practice, that, wow, I do feel a lot better, and all I did was stop gluten.
Unfortunately, humans are very adaptable. Fortunately and unfortunately, we're very adaptable. We get used to our new normal, and we don't recognize or remember what it felt like to feel really good. I mean, the other side of that, of course, is those patients might be averting onset of a disease 10, 20, or even 30 years down the line due to antibody production against the transglutaminases like TTG6 in the brain, or TTG3 in the skin, or TTG2 in the gut. And that's something that you can't really subjectively experience, the production of those antibodies in the body, gradually degrading microglia or something in the brain.
Well, absolutely. And not only that, it's that the incidence of other diseases, cardiovascular disease, for example, is higher in untreated celiac disease. It's an inflammatory disorder, and functional medicine is all about decreasing sources of inflammation. So it's documented. I mean, there's good studies showing that you have higher rates of cardiovascular disease in untreated celiac disease, higher rates of other autoimmune diseases, but you probably also have other rates of cancer, and you have a shortened lifespan unless you treat it.
Sure. Yeah. And I mean, pretty much all modern chronic disease is inflammatory in nature. So the diseases that we know there's an association with are just the ones that have been studied. It doesn't mean that others there isn't an association. Lack of evidence is not evidence against, right?
Absolutely.
So you recently went and spoke or presented a poster at the International Celiac Disease Symposium, along with Laura, who you mentioned, and Nick Waring, who's a former patient and now a student in medical school. So tell us a little bit first about this conference, because it's an interesting conference, and then we can go into your poster.
Okay, so this is International Celiac Disease Symposium, which is the largest celiac disease conference. It happens twice a year. Sorry, every other year. And the last time was actually in India, and I'll get to that later. You might think there's no celiac disease in India, but it's not true. And it's a group of very, very dedicated researchers and a few patient advocacy groups who are really trying to solve problems around celiac disease in terms of everything you can think of: diagnosis. Why are the rates of celiac disease going up? They're asking questions of what can you do to treat celiac disease. It's a very interesting group of people there. Some are food scientists. They're looking at wheat and has that changed, and what, is that the trigger? What in our food system is an issue? And so there's a lot a lot of really good science going on there.
Were there any other functionally oriented people there, or was it pretty much 100% conventional medicine?
Sadly, to my knowledge, I was the only functional medicine person there. I mingled with a lot of people, and I speak French, so I was speaking to some of the people that it was in Paris, so there were a lot of people from France, and I didn't find anybody who was functional medicine oriented, except for a few patient advocates that were there that knew about functional medicine.
Did you get any blank stares or worse scowls or of recognition about functional medicine?
Well, to be honest, I was very careful of what I said. I did ask a lot of questions during a lot of the scientific sessions, but my goal was more to learn from them. I knew that changing their approach on this is not going to be a one-man show.
Yeah, absolutely.
I wouldn't be able to do that.
It's interesting. As a total side note, I've found, the awareness of functional medicine in Scandinavia is really high. We both have a colleague and friend in Sweden, and there are many others. I've spoken, traveled to Stockholm and presented there. And it's also very high in the UK, but on the continent is really, really lagging behind in functional medicine awareness. I'm not sure why that is, but I've had a number of doctors that are aware there complain to me about that. So yeah, tell us a little bit about your abstract and study, because I think it's fascinating and certainly could lead to some interesting avenues of further research.
So I've noticed I test everybody for celiac disease and for Lyme, and I've noticed that a lot of people test positive for Lyme disease that also have a really high celiac genetic risk. So when I test people, I have an unconventional approach, as you all might imagine, of testing people for celiac disease. I test everybody for celiac genetic risk. That is not what we're supposed to do according to normal guidelines.
The algorithm.
Right. Yeah. But I do that for several reasons. I think that it's important to know your genetic risk. And a lot of our patients are already on a gluten-free diet, or they're eating small amounts of gluten or maybe trace amounts of gluten. So it really is important to know their genetic risk. And then I will test their antibodies, TTG, but also the antimycel antibodies. And I'll do IgA and IgG testing on most patients through a panel at either LabCorp or Quest. My preferred panel at the moment is at LabCorp, but that changes from time to time. But I also noticed that a lot of the patients testing positive for Lyme they have a high genetic risk for celiac. And so I wanted to study that connection in more detail. And so we did an analysis, Laura Montgomery at CCFM and I, and also Nick Waring helped in analyzing all of our patients from any of the providers that presented to CCFM. And we found that about the 41 patients that had a high celiac genetic risk and a test for Lyme, 24 of those had significantly positive tests for Lyme disease. And then if you add in,
and that was using the CDC criteria,
correct,
to be clear, which are well accepted.
Exactly, that was using CDC criteria. If you are a little bit looser and use an ELISA or non-CDC criteria, we would have 68% of those testing positive for Lyme. And we know from experience that a lot of our Lyme patients feel better when they're off gluten. And there's a lot of reasons that people with an inflammatory disease or an infection might feel better off of gluten. But the correlation between high celiac genetic risk and a positive test for Lyme disease was very interesting to me. And so I really wanted to put that out there in the scientific world. And we wrote this poster as a starting point of perhaps doing more studies and involving more researchers in answering this question. And I developed a connection with a scientist, Dr. Taylor, who she's the one that actually has done a lot of studies on celiac genetic risk. And we might be interested in performing some more studies and querying large databases of lab tests that have already been done to see what we can learn from that data. And it's a very interesting field, a very interesting association. It leads to a number of questions too. Is it that the patients with a high celiac genetic risk will be sicker from Lyme disease if they get it? Are they more susceptible to Lyme disease? Are some of these patients having false positive tests for Lyme disease? Or what is out there? And we really don't know. And to be honest, like in a lot of things in medicine, it's probably not one thing. It's probably, some patients have had, in some of the patients that I've seen and treated, we looked at 10 of them in more detail. We take away the gluten and they feel better. In some of them, they're pretty sick, so we take away the gluten and we treat Lyme, and then they feel better. And in some people, we just treat the Lyme, and for other reasons, they weren't able to take away the gluten. For example, one of them was a chef, and makes it difficult. Livelihood depends on cooking in a non-dedicated gluten-free facility. So there are caveats. It's an interesting field.
Yeah, it's so fascinating. I mean, I when you first gave that and shared the results, I was thinking a lot about what the various mechanisms might be in both directions, and we, as you said, we often have a tendency to want to pin it down to one factor or create a one-way kind of linear chain of causality, but it's so often not how it works. It's much messier, and almost if you look at the diagram behind your head that we created for CCFM, that's probably a better visual representation of what's going on. But what I'm curious what you think. I'm sure you've thought a lot about this too, and we obviously don't know the answer. And in science, you're often not encouraged to speculate, but I'm going to encourage you to speculate. And what's your gut sense, pun intended, of what might be happening here?
Well, I think that there is probably some merit to the idea that people with a high celiac genetic risk would be more susceptible to Lyme disease. And I think, or at least the chronic manifestations of Lyme. I do think that plays a role. And it's celiac genetics are somewhat complicated. It's not just the two genes. We call them HLA, DQ2 and DQ8. And if you don't have those genes, you're probably not going to get celiac disease. You can still get chronic Lyme disease, but if you have those genes, perhaps if you get a tick bite and you develop Lyme disease, perhaps you'll be more susceptible to getting the chronic manifestations. My gut sense is that that's what's going on.
So clarifying question, do you think it's the genetic disease risk that is responsible for that association, or do you think it's the untreated celiac itself and the manifestations of that, like the inflammation, the inflammatory milieu, that is responsible?
Very difficult to say, but I think that they're probably both playing a role. That you can't separate one from the other. But some of these patients probably do not have celiac disease. I don't have biopsies on all of them to say for sure. And as I mentioned, a lot of them were already on a gluten-free diet. So it's difficult to say how much, definitively if they had celiac disease. But probably some of them did not have celiac disease, and they have just the genetic risk, and they still have the chronic manifestations of Lyme. But let me clarify something, that 30% of people of the American population carry DQ2 or DQ8. So 30% of that population has a risk for celiac disease. I didn't just use that risk, however. I tried to narrow down that population to the ones that have a higher risk. So the genes that I used in my study probably represent fewer than 10% of the American population. So I was quantifying the celiac risk depending on which specific, they're called haplotypes, but which specific genes, if you will, or alleles that our patients had. And I was using the higher risk ones. So there is probably something in both directions.
Okay, that's good to know. And you stratified the risk further, and we're choosing those that were at the highest risk. And what do you think it is about DQ2 and DQ8, or that high risk haplotype? Like, what is it that those genes are doing? What proteins are they coding for, or expressing, that would put somebody at higher risk? Or is that just we have no idea at this point?
Well, so they're human leukocyte antigens. So they're in the HLA genes. You might have heard about that for typing for transplants. So when you have to have a kidney transplant, you have to have an HLA match, for example. And so they're antigens on human white blood cells or leukocytes. And they are responsible for T cells. So the T cell response is we also call that the cell-mediated immune response, is one of the major parts of the immune system that plays a role in celiac disease. And one of the interesting facets here is that they help, it's involved in T cells, and T cells are involved in your memory response. So these T cells, once they become activated against gluten, and we don't know exactly how that works, but we have some ideas, they store that memory for a long time. But it's not that they code for specific proteins like some other genes that you might think of, because these are in the HLA, these are HLA genes, so we have to think about them slightly differently. And then another interesting facet is that if you use 23andMe, for example, or one of the online genetic testing services, they test for SNPs, or single nucleotide polymorphisms. And SNPs test for differences in genes, but some of the SNPs you can't test all of the HLAs through SNPs. So certain SNPs, so through 23andMe, you'll miss
some people who are positive.
Exactly, like my daughter, for example, she's had 23andMe negative genes, but if you run the genes through a different kind of specialty lab, she does have DQ2.2. So you can miss some.
That's really important point I want to emphasize, because a lot of people are relying on consumer genetic tests like 23andMe to get this type of information, and it's not always reliable. Much better, I think, to use a lab like Quest or another reference lab that is going to give us much more evidence-based, reliable information on these haplotypes.
Absolutely.
So let's kind of zoom out a little bit and talk about these particular haplotypes. What do we know about when they arose, why they may have arisen? Because Certainly if there's a genetic thing that has been preserved in the population for a long period of time, it must have had some original. I mean, certainly there are spontaneous mutations that occur, but if it's persisting for as long as it is, why is that?
That's interesting, and there was some talk about that at the conference. It's thought to probably protect against certain infections, but we don't know that to a high degree of certainty. We think that there has to be some evolutionary utility to having this. In malaria and sickle cell disease, for example, that's very clear that sickle cell protects you against malaria. So that's why it's a deadly disease. But in celiac disease, it's a little less clear. It's not well understood why 30% of the population, and this is probably of the world, have genetic susceptibility to this disease.
Yeah, I know hemochromatosis, there's a similar theory that people who increased survival rates during the bubonic plague in medieval Europe. And so a large percentage of people who survived had the genetic, they were either carriers or homozygotes for those mutations, C282Y or H63D. And then because the population shrank so dramatically, then they became sort of the founding population for our ancestors, basically. Even though, of course, hemochromatosis increases the risk of dying from other infections, it would have conferred a protective effect there. So it's really fascinating to me to think about these things, even though they're not necessarily directly relevant to what we're going to do about it. Let's move on to something a little more practical, maybe, which is just this growing incidence of celiac disease. What are the latest statistics that you heard, if they covered that at the conference, and in terms of prevalence, both in the U.S. and worldwide? Is it increasing? Do we have solid evidence of that?
We do. We definitely have solid evidence of it increasing, and in the developing world, it tracks to increasing wheat consumption pretty nicely. So take China as a good example, where at least we have thought traditionally that people of Chinese ancestry don't have a high risk for celiac disease. But if you look in parts of China, and you can use the Yangtze River to cut China into north and south, and in the north, they can't grow rice because rice needs a more temperate weather, but wheat grows pretty well. And so if you look in the wheat-eating communities in northern China, for example, in some studies, there's as much as 2.3% prevalence of celiac disease. In the US and in already developed countries, we're not eating more wheat than we used to. We're eating about the same. And so why do we still have in the US an increasing problem with celiac disease, or increasing incidence and prevalence of celiac disease? And there is no good answer. There was one interesting study, and we always ask, is it the wheat that's changed? What are the options? Is it the wheat? Is it the pesticides or other toxins? They actually use microbial transglutaminases, which, as food additives that you don't necessarily have to declare on the product label, except if you're in Switzerland. And, those have been more common. And also another thought is vital gluten. Vital gluten is an additive that is put into some commercial bread products, for example, to make them gooier and make the taste better. But the question of has wheat changed was addressed specifically. The other questions were not at the conference. And there was a very good study in Germany that looked at wheat cultivars from 1890 to 2010. And they went into enormous detail here. And I'll spare you all of that detail because it's excruciating and an excellent study. And these are food scientists that did this. They did it without pesticides, without fertilizers, to mimic the same conditions that were present as early as the early 1900s. And they did not detect a significant difference in gluten content over the most common cultivars of wheat, the most recent decades versus the earlier decades. So it probably, according to them at least, and in Europe or in German wheat, there isn't a huge change in the gluten concentration.
Did they compare European wheat to American wheat? Because I know you've heard this before from patients, where we have patients who go to Europe and eat wheat there and have a totally different response to wheat in the US. And of course, that could be many things. They're on vacation, their stress is lower, but could it also be that, the wheat that's being used in Europe is qualitatively different than the wheat in the US?
I see that a lot, that patients in, here, as you said, Chris, that will go to Paris and they'll eat a baguette and they'll have no problem. And then they'll do the same thing in the States and they'll have a problem. And I can speculate a lot. And, are they putting additives in our bread? I always tell a story to my patients like this. You can take a baguette that you get at 9 a.m. in Paris, and you can take it to the baseball stadium. Not that they play baseball there, and you could probably hit a home run with it at 5 p.m.
That's right.
Okay?
It's hard as a rock.
Exactly. But and the same baguette that you buy at your local Whole Foods would still be soft at 5 p.m. Mm-hmm. Now, why is that? I'm not an expert in that exactly, but are they using additives like microbial transglutaminase? Are they that will actually increase shelf life and make the bread stickier? Are they using other preservatives? Is it that we use pesticides or herbicides on our wheat crops? Some people say that, and some farms probably do use some glyphosate to make the wheat germinate a little bit more quickly. So it's a complicated question. But also, one other factor that we have to think about is what's the state of your nervous system when you're in the U.S. versus on vacation in Europe, right?
Mm-hmm. Yeah, so I think that's a big factor that's often underappreciated.
Right. So some foods might have require more energy to digest, if you will. And if you're in stress mode, work, and you eat some gluten in the States and you don't have celiac disease, you might feel more of an effect than if you're totally relaxed on vacation, eating at the beach in Italian Riviera, and you have a sandwich or a fresh baguette there or something. You might not feel the same effect.
And that's not just true of wheat. That's true of a lot of foods that people react to. I've seen with my patients, and even things like alcohol and caffeine. Like people can have a triple espresso in Italy while they're on vacation and feel fine, but they do that at home when they're in the course of their normal life and stress levels are high, and they feel like they got plugged into a socket. It's a totally different story. So let's talk a little bit about kids. So let's say you're a parent, you have a very young child, you've got a baby, or you've got a 2-year-old, and they're just about to start eating. And you've heard these conflicting reports about whether you should sensitize your kids to allergens like peanuts and maybe like gluten. Should you feed them a little bit of gluten to reduce their, potentially reduce the risk of celiac and gluten intolerance? Or should you just avoid gluten until they're older and their immune system is more developed? You mentioned already that in some of these other places, eating more gluten is associated with higher incidence of celiac disease. So where do you come down on this whole question?
Well, it's interesting. And there were a few studies looking at that question even during pregnancy. And this is one of the reasons I like to know a patient's celiac genetic risk. So if I have a patient who's comes to see me and she wants to have a baby, and you know, and as we do, we see patients
Sure.
prenatally sometimes, and one of the tests I would include would be celiac genetic testing for her and her husband. So that way I'll know if there's a potential for celiac disease in the baby. And that way we can counsel the mother, because this is one thing that seems relatively clear in the literature, that even if the mother is breastfeeding and eating gluten, and the baby is not eating anything except breast milk, that can be a risk factor for celiac disease in the susceptible baby. So if the baby has genetic susceptibility, let's just say, for example, that the baby's dad has celiac disease and the mom doesn't have the genetic risk. If the mom eats gluten and the baby got the genes from dad, then the baby is at higher risk of celiac disease, even if the baby's only eating breast milk. And so that risk also translates to when foods are introduced. It's about the quantity of gluten consumed, perhaps more than the actual time of introduction over the long haul. So I think that is a very interesting field. And yeah, in adults and children, it does seem to be that the time of introduction isn't maybe as important as the amount of gluten. However, in one study in Italy, they assessed in children when do you, if a child has a genetic risk for celiac disease, when do you need to stop testing them? So if the child had a test at 4 years of age, then they were not very likely to get celiac disease later on in childhood. And certainly if you test that child at 9 years of age, they had almost no risk of developing celiac disease in childhood. And the pediatric guidelines say you can stop testing the child there forever. But the adult guidelines, and this is a very interesting part that needs future research, no, we know in adulthood that there's another peak. There's another group of these patients that develop celiac disease in adulthood. And why is that? And so we can't just stop screening, and probably cumulative gluten intake is important. But in a child, if you get to 6 years or certainly 9 years of age and you don't have celiac disease, even though you have a risk, you're not likely to develop it at least until early adulthood.
That's fascinating, and I imagine will be a bit of a relief to some parents who are struggling with the question of, oh my God, if I feed, if my kid has a tiny bit of gluten, are they going to develop celiac as a result of that? And on the flip side of that, do I need to be like methodically giving, titrating gluten exposure with my kids? It doesn't really seem to work that way from the research that we have now.
Right.
So let's talk a little bit about any other, what do we know at this point about, I kind of want to rewind and contextualize this in the question of why is celiac prevalence increasing? I've had it's not just celiac prevalence that's increasing, it's all autoimmune disease, right? We have now 80 autoimmune diseases have been identified, or 90, and that number is growing every year, and the rates of all kinds of autoimmune diseases are going up. And it seems to me that there's my theory is it's some combination, of course, of modern diet and lifestyle, and then the impact that has on our gut, and then the gut and intestinal permeability, as L.Ac has argued, being an important precondition in the initiation of autoimmune processes. So if someone does have, let's say you work with a pregnant woman, you do testing, you find out that she and or her husband is at a high genetic risk for celiac, and therefore their son or daughter is going to be as well, how would you counsel them to prevent that haplotype from expressing? What are the things that are important for them to keep in mind, both for themselves and for their children?
So one of the big take-homes, just taking another step back from the conference, especially on the conventional side, is that you don't want to limit a person's diet if you don't have to. And I think that's also what we believe in functional medicine. You don't want to limit a person's diet if you don't have to. However, we know that certain things are inflammatory, and there's some component here of eating for your genes, like eating for who you are culturally and what your genetic background is. And so we also have to think about eating in quantities and processed foods and not processed foods. And so in this couple, where they both have a high genetic risk, I would try to find out if they feel better off gluten or not. And I would say if they say, well, I feel much better off gluten, even though I don't have celiac disease, but I feel better off gluten, I'd rather eat paleo, or I'd rather eat a Mediterranean paleo diet or something, but I just avoid gluten, then I would advise them to, since that's how they feel better, their child will probably be similar, then they should avoid gluten. But they don't necessarily need to limit gluten in the child. So I would have the child tested for celiac genetic risk. LabCorp, for example, can run a specimen off of a cheek swab. So you can do this on a baby without drawing blood, which is great. And so once the baby's born, you'll know that baby's genetic risk, and we're going to assume it's high. So then it's a matter of what the parents feel best with. There's no right answer, first of all. And we're going to screen that baby for celiac disease once a year with a blood test if they do have that high genetic risk. That would be a strong recommendation. So while we're doing that screening, we're going to, the baby will be seeing their pediatrician and getting regular checkups. If anything is amiss, then definitely that baby should be off of gluten and probably have a biopsy to look for celiac disease at that time. Then, but assuming not, I would say let the baby stay in your gluten-free house. But when the child is old enough to go to parties, if they want a cupcake that everybody else is having, let them have that cupcake. And I have a child who can't have that cupcake, and it differentiates the child. They're not part of the pack. There's a social and behavioral cost to avoiding gluten in social contexts. It can be isolating for a child who doesn't understand the dynamic.
Yeah, our daughter Sylvie has a mild gluten intolerance. She's not celiac. It's more of a quantity thing with her. Like if she eats a lot of it, we definitely notice things. But we've tried, if she goes to a party, in the Bay Area, often when you go to a party, there's gluten-free, dairy-free, vegan, raw, whatever. So it's not as much of a concern. But in many, in some cases, we go to parties and there isn't, and we tend to let her have that for that exact reason, even though it's probably not optimal, and she has some mild reaction. In our calculus, it's been like the benefits of her just being able to do that and not see herself as someone who has that issue is, everyone has to make their own decision with that. But I agree that there's definitely a cost there to consider. Let's talk, we're getting to the end of our time here, but I want to, and we'll definitely have you back because there's so much more to cover on this subject. We're really just scratching the surface, but let's finish with diagnosis. Cause that's, if someone is wondering and listening to this, if they have celiac disease, what, in addition to the HLA-DQ genes we've been talking about and the genetic susceptibility, what about actual markers that confirm or rule out celiac?
So the standard marker is the tissue transglutaminase IgA. That's the most accepted marker worldwide in terms of diagnosing celiac disease. And if you did tissue transglutaminase sub-markers, it's TTG-IgA2 or TTG2-IgA. That's the marker that, if that's more than 10 times the upper limit of normal, then most people worldwide agree that's celiac disease. And if you have the genetic risk, that can clinch the diagnosis without having to do a biopsy. So let me take a further step back, that before you decide to go on a gluten-free diet, or before you commit to a long-term gluten-free diet, at least think about speaking to your doctor about getting a test for celiac disease. Because if you think that going gluten-free and you have some gut symptoms, or as Chris mentioned, a lot of the symptoms are not gut related. They can be multiple symptoms, from fatigue or ADD to neuropathy to arthritis and on. But if you're going to stop gluten, you need to think about getting a test for celiac disease. And most doctors will order a TTG-IgA. I will order a much more comprehensive panel, including TTG-IgG, endomysial antibody, as well as
so I think what Mayo Clinic is using as a screening marker now, endomysial antibody.
That has a very high specificity for celiac disease, and it can be used as a confirmatory test if you have questions. The interesting thing here, and the new science, the new developments are coming out, and what do we do with our patients who are on a gluten-free diet, and we think they might have celiac disease, but it's actually quite important to know if you have celiac disease. And so how do you make that diagnosis? Well, the good news is that there are 2 different lines of tests that are in clinical trials that are hopefully going to come out soon. And I'm talking to one of the companies trying to get some patients enrolled, so far without success. But there are two methods of looking at, here's a quick gluten challenge. I'm going to give you a standardized dose of gluten in this standardized cookie. You eat the cookie. I'm going to do blood tests right before you eat the cookie and right after you eat the cookie. And if your levels of inflammatory markers in the blood go up, then that's celiac disease. And so, and that can correlate to a high degree of certainty whether you have celiac disease. And there's another method of testing. They're called HLA tetramers. It's kind of confusing science, especially to me, and I've spent some time trying to figure that out. But HLA gluten tetramers, and a similar thing, those can test for those memory T cells that we talked about before, to see if you have any of those memory T cells to gluten without having to do any gluten challenge or just a limited gluten challenge. And that's 2 lines of testing that will hopefully be on the market, I'm guessing in early 2021 or 2022. So we're a couple of years away from that. In the meantime, if you're already on a gluten-free diet, in this country, there's no great way to test except by doing a formal gluten challenge.
Without a lot of pain and suffering if you already know that you are gluten intolerant. Yeah, and I understand that in a lot of places, biopsy is being avoided in kids as well because of the invasive nature of that procedure.
Right, and that's also diagnosing celiac disease without a biopsy. If you have very high levels of TTG-IgA, is probably okay, but in others, you should probably do the biopsy. In my daughter, she had very high levels of all of the markers, and her TTG-IgA was about 20 times upper limit of normal, so very high. And there was no question she had weight loss. There was no question. We did not do a biopsy, but we're very strict on gluten avoidance, and we can talk about gluten avoidance and what a celiac diet looks like, at least to me, later. But I'm thinking of going back and doing a biopsy just to confirm. My take is that if there's any residual abnormality in a child or adult who had celiac, is on a gluten-free diet that's very strict, and there's still anything going on, you should do a biopsy to make sure they don't have refractory celiac disease or some other condition.
Right. Well, Ramzi, this has been really fascinating, and I think we should definitely do part 2 because there's still a lot that we haven't had a chance to cover. And in the meantime, where can people find out more about your work and learn how to become a patient if they're interested in, getting some of this testing and figuring out if they have celiac, and then, of course, knowing what to do if they do have it?
Absolutely. Go to our website, our clinic website at ccfmed.com. You'll find out about our profiles, and on social media now we've posted a little bit of work and the abstract that I've done. And feel free to contact us, and we'd be happy to consult or see you as a patient if you're interested.
Great. Well, let's get that part 2 on the schedule. I want to continue this conversation. In the meantime, thanks everybody for listening. Hope you got a lot out of this, and thank you, Dr. Asfour. And we'll see you next time.
All right. Thank you, Chris.
That's the end of this episode of Revolution Health Radio. If you appreciate the show and want to help me create a healthier and happier world, please head over to iTunes and leave us a review. They really do make a difference. If you'd like to ask a question for me to answer on a future episode, you can do that at chriskresser.com/podcast question. You can also leave a suggestion for someone you'd like me to interview there. If you're on social media, you can follow me at twitter.com/chriskresser or facebook.com/chriskresser L.A.C. I post a lot of articles and research that I do throughout the week there that never makes it to the blog or podcast, so it's a great way to stay abreast of the latest developments. Thanks so much for listening. Talk to you next time.